I'm here to talk to you about precursor conditions, MGUS and smoldering myeloma, things that put you at risk of developing multiple myeloma. And I'm also here to talk about treatment of newly diagnosed myeloma. And as Jenny would say, it's supposed to be 90-10, 80-20. You may not catch everything. That's not going to be the case for my talk. It's 100% in my talk. The rest of the people you may not understand. But this talk is supposed to get the big picture. And I think you're going to have excellent understanding and comprehension of what I'm going to talk about today. So what am I going to tell you? I'm going to tell you what are precursor conditions, and then whether you should take treatment to delay the onset of multiple myeloma. I'm going to tell you what is myeloma and what's new about clinical trials and treatment for newly diagnosed myeloma, specifically focusing just in case there are those folks like Myeloma Teacher who are on Twitter, on social media, looking for stuff. There's some presentations. The International Myeloma Society had a meeting in Toronto just last week. You might see a big splash about Majestic 5. And so I'm going to talk about that for a quick minute. And then I'm going to talk about one slide of just general guidance for patients. So in general, monoclonal gammopathy of undetermined significance is one of the dumbest names ever because this describes, it's MGUS, and MGUS is not very understanding of what this is. Basically, you have monoclonal plasma cells in the bottom left there, and they make a monoclonal protein, and we can do a blood test looking for these antibodies. These antibodies are all exactly the same size and same shape. And so when you see them on this gel electrophoresis, now gel electrophoresis, all it is Jell-O. If you've ever made Jell-O, I've made Jell-O exactly once as an adult, but unlike my kitchen, you electrify the Jell-O, again, not something you do at home, but that's what serum protein electrophoresis is. It's Jell-O where we put in your blood and then electrify it. And then negatively charged proteins go towards the positive end, and it sorts it by shape. And what you're not supposed to have is a spike, a group of antibodies all exactly the same size and same shape, made by a group of abnormal plasma cells that are very, very similar, all making the same product. You're supposed to be like Atlanta, a diverse number of antibodies. And in patients with MGUS, you are mostly diverse, but you have one clump of antibodies all exactly the same size and same shape, meaning you also have a clump of plasma cells who are all very, very similar. Now, this is the only, I think, if I'm getting this right, this is the only Kaplan-Meier curve. On the vertical axis, it's patients with progression or death. Horizontal axis, years since diagnosis. And what you can see is that many of these patients go on to die of something else. I know that's not a particularly positive way to look at life, but that's functional cure right there. This doesn't mean that MGUS impacts on your life. And these folks down here, the smaller group, over many years, a minority of patients with MGUS go on to develop multiple myeloma. In the precursor condition world, there are two conditions. One is MGUS, which is a small amount of abnormal plasma cells. The next group is smoldering myeloma, the world's second dumbest name. Now, smoldering myeloma, any normal person thinks that's myeloma that's just put on simmer. That makes sense, but that's not what it is. Smoldering myeloma is another precursor condition. So basically, if a patient eventually develops myeloma, at one point they met criteria for MGUS, at another point they met criteria for smoldering myeloma with essentially more abnormal plasma cells, and then finally, if things don't go right, they develop multiple myeloma. And there's a recent study they did in Iceland where they screened thousands of patients, and they found that the prevalence, or just how many of the random population had smoldering myeloma, was 0.5%. More men than women, and the prevalence, or how common it is, increased with age. And you can see that on the horizontal axis as we get older. Smoldering myeloma and MGUS and myeloma becomes more common. So, MGUS on the left-hand side, small number of abnormal plasma cells, degenerates to smoldering myeloma, abnormal plasma cells. And what differentiates them really is when these cells attack the patient. Now, in breast cancer, colon cancer, prostate cancer, lung cancer, if you have any one of those cancers, if you get a biopsy of a breast mass that's breast cancer, the pathologist calls you and says, hey, this is cancer. Or the pathologist calls you and says, hey, this isn't cancer. In myeloma, the pathologist calls you and says, there are 6% plasma cells, there are 10% plasma cells, there's 40% plasma cells. Have a nice day. They don't tell you whether it's cancer or not, because cancer is based in general on behavior. Are these cells trying to kill the patient? Are they chewing at the bones and spitting the calcium in your bones back into your blood, causing high calcium? Are they filling up your bone marrow, making it difficult to make normal red cells, causing anemia? Do they make antibodies that clog your kidneys, causing kidney failure? These are evidence that these cells are trying to kill you, and that is really the definition of multiple myeloma. You can't tell just by looking at it that these cells are cancerous. We recently figured out, or relatively recently figured out, that waiting until clear evidence of holes in your bones or kidney failure is too long. So maybe we can move the goalposts earlier, so we can find patients who have, in general, a 75% chance in the next 2 years of developing symptomatic myeloma. So these patients have, for instance, 60% abnormal plasma cells on a bone marrow biopsy. They may have a serum free light chain ratio, kappa to lambda or lambda to kappa, greater than 100. Or they could have multiple abnormalities on MRI of the bone, small areas greater than 5 millimeters, and have multiple ones. Any one of those can push you into being called multiple myeloma, because you have a greater than 75% chance in 2 years of developing fractures, anemia, or kidney failure. And so on a spectrum, what really do you need for the diagnosis? Each one of these, on the left-hand side, you can see what you need for MGUS. You basically need abnormal antibodies in your blood. Smoldering myeloma is basically just more of those cells. On the left-hand side in green are pre-cancer or precursor diseases, where they do not attack really the patient. On the right-hand side are patients that are symptomatic. And in the multiple myeloma, these are plasma cells that are attacking the patient. In AL amyloidosis, it's in general the antibody produced by these abnormal plasma cells that is attacking the patient. So on the left-hand side, things that in general don't need treatment. On the right-hand side, things in general that absolutely do need treatment. So after I tell patients this in the clinic, I say, well, you have a precursor disease, and this puts you at risk of developing a blood or bone marrow cancer in the future. And I often say, if you sit with this for a little bit, you'll then ask me, well, what is that risk, doc? How likely is it that I'm going to develop multiple myeloma? Because my brother lives in San Francisco. There's going to be a destructive, totally crushing earthquake in San Francisco. We know it's going to happen. It's going to destroy hundreds of buildings, cost thousands of dollars of damage, and it's going to happen sometime in the next 10,000 years. It's hard to really figure out what to do with that. So knowing what your risk is to develop multiple myeloma is very helpful. So you can take, using one of our little medical calculators, we can plug these things in. You can take the serum free light chain ratio, that gives you a number of points. Then you go down there and you can get specific abnormalities on a bone marrow biopsy called FISH, looking for colors of abnormalities seen on bone marrow biopsy. You go down a little bit, you see a monoclonal protein. Do you have, how much of that do you have? Well, each one of those comes to a number of points. And at the bottom is how many, what's the number of abnormal plasma cells on bone marrow biopsy? And that's associated with the number of points. So on the right-hand side, you total them all up. And so all of my patients with smoldering myeloma, I have this little chart there. I'm assigning them points. And this is what you get at 2 years and at 4 years. It's not exact, it's not perfect, but at least it gives you some idea about what's going to happen. Yes, there's going to be a devastating earthquake in San Francisco, 10,000 years. This is a little bit better than that. It ain't perfect, but it's a little bit better. And you can see that patients who have a risk of progression at 2 years of 50%, 4-year progression 70%, some of those patients may look at that risk very individually. And they may look at it like, I want to do something about that. And other people look at that risk and they don't want to do a darn thing about it. And they just want to continue to see me and watch this very closely. Risk is individual. And you look at risk and I look at risk in a very personal way. And my job is to tell you the risk and then try to figure out how to deal with it. So this question has been around for a long time. And I'm going to tell you quickly about 2 trials that are targeting intervention for patients with smoldering myeloma. And the first trial is Aquila, which is Darzalex or daratumumab. It's a CD38 antibody. It just targets the CD38 on myeloma cells, and then your immune system comes over and sucks up the combination of the antibody and the abnormal plasma cell. That's really how it works. And patients got daratumumab or Darzalex, or they didn't get anything. And we watched what happened. This in smoldering myeloma, where the standard of care is really not to intervene. Interestingly, this was defined as so-called high-risk myeloma, with criteria you can see on the left-hand side. And that criteria doesn't really correspond to any particular percentage likelihood to develop myeloma in 2 and 4 years. So it's a very wide swath of patients with smoldering myeloma that were enrolled onto this trial. And they had clonal bone marrow plasma cells greater than 10%, and they had one of these other risk factors here. And it's quite a lot of little risk factors. But suffice it to say, they were targeting patients who were more likely to develop multiple myeloma than not, and were willing to consider some intervention, in this case, daratumumab or Darzalex. The other trial, looking at the intervention in patients with smoldering myeloma, is delightfully named E3A06. And this is Revlimid or lenalidomide versus observation. Same general idea. These patients had bone marrow plasma cells greater than 10%, no evidence of myeloma bone disease. Some of them had a high serum free light chain ratio. Some of them didn't because it's hard to accrue to this trial. But basically, they had Revlimid versus observation. That's the idea. Same idea in both trials. So what's the unauthorized biography here of these 2 trials? What's the results? In general, did we see objective evidence that these treatments would work? 50% of the time in patients on Revlimid they did, 83% on daratumumab. How long was the myeloma under control and the patient alive? So 3.9 years in observation, 7 years on Revlimid. In the Darzalex or Aquila trial, 1.5 years versus 4. And you can see it's kind of like, no matter what I do, it's about twice as long that the smoldering myeloma remains under control. That's in green. That's the positive stuff. The negative things are, well, how often would you get infection requiring hospitalization? Approximately, for those patients on Revlimid, 12%. We honestly don't know in those patients who didn't receive Revlimid what the percentage was. So those folks on observation. Whereas on the Aquila trial, they said 16% were hospitalized versus 4.6%. So taking daratumumab increased your likelihood of being hospitalized for infection threefold. Fatigue so bad you have difficulty doing your activities of daily living, getting dressed, walking around, taking a shower, 8% versus less than 5%. Severe rash, Revlimid is known to be associated with rash. Hypertension, I don't really understand that as well. And finally, diarrhea or dehydration, more common in patients on Revlimid. And then cost per month, nothing comes free in US healthcare, and it ain't cheap. And then looking at this is a little bit, how do you think about risk? What makes you feel better about your smoldering myeloma? Because patients with smoldering myeloma are at risk, these interventions are not curative. They delay the development of multiple myeloma on average. So early treatment with daratumumab offers patients with high risk longer time before they develop myeloma. If you don't get treated on one of these things, you generally need some sort of thoughtful follow-up, meaning getting your myeloma labs done every 3 months, sometimes getting imaging, sensitive imaging, PET scans or MRIs, if you have changes in your so-called myeloma labs. This makes good sense, and you want to, on average, do something better than the patients on the Aquila trial or E3A06, because you, as a patient, and me as the doctor, don't want you to have fractures, anemia, and kidney failure that is part of the diagnosis of myeloma. How do you think about myeloma? In general, I think about myeloma, the development of myeloma, as termites. And these termites, in general, chew at the foundation of your house, which is your skeleton. And chemotherapy is trying to kill these termites. And the reason we haven't cured myeloma is that there might be a myeloma queen bee, a queen termite, a myeloma stem cell, whatever you want to say. We have not been effective at eradicating myeloma in the vast majority of patients. So it always in some way comes back, no matter what treatment I give. In general, trying to understand what type of myeloma you have is very, very helpful. In the myeloma support groups, they often introduce what type of myeloma you have based on the protein you excrete. I'm an IgA myeloma. I'm an IgG myeloma. That's not the type of myeloma you have, and it's not relevant. What's important is what kind of myeloma you have. Is it easy to treat, or is it hard to treat? And risk, when we see patients with myeloma, is all about, is it easy or hard to treat? And so we look at blood test values, beta-2 microglobulin at diagnosis, albumin, and genetic and blood test features to try to figure out who has low-stage myeloma, which is easier to treat myeloma, and those patients with high-stage myeloma and harder to treat myeloma. If you think, all right, so these are the toughest 2 slides. So just bear down, hang tough, you can do it. So this is how we think of risk in myeloma. Patients who have high-risk myeloma have a variety of genetic abnormalities specific to their myeloma. This is in general obtained on bone marrow biopsy, specific markers, genomic testing generally needs to be done to assess all of these things. Intermediate risk myeloma is your standard revised ISS-3, some more genetic markers, and then we add, hey, do you have circulating myeloma cells? Is your myeloma so tough it can handle I-75 in Atlanta, which is the bloodstream. It's a hard area to survive. Does your myeloma go inside other organs? And we call that extramedullary disease. Or did you not have a great response, so less than a very good partial response after 4 to 6 cycles of initial treatment? That puts you in the intermediate category. And then standard is everyone else. And then we think about patients who are frailer, both as standard risk and high intermediate risk as above. How does this make a difference? How does this help us define treatment? Well, just take all the things I showed you from the previous slide and move them to the left. Now you have high risk, intermediate risk, standard and frail. Here are the characteristics, same characteristics on this slide as the last slide. But then what do? And basically, in our fit patients, which is these 3 rows here, we give them 4-drug treatment, we think about autologous transplant, and then we either do 3-drug maintenance, 2-drug maintenance, 1-drug maintenance. What can be simpler? And for frail patients, those patients who are in general, the idea of an autologous transplant is not a good fit. Those patients generally will start with 3 to 4 drugs initially, and then eventually prune that down over time with good response to something more tolerable, ultimately usually down to 2-drug maintenance. Okay, so last week in Toronto, International Myeloma Society. What's new in myeloma induction? This is how the first title slide goes when myeloma doctors present at meetings. And this gobbledygook title, which is definitely intimidating, but basically it's saying, hey, can we add a bispecific antibody to that 3 and 4 drug regimen you just talked about? Will that be better? And in general, the idea is that there were a number of arms with a small number of patients, and they were adding teclistamab at various doses and frequencies, but they're adding it to daratumumab, Revlimid, dexamethasone, plus or minus Velcade. So they're adding it to a 3 or 4 drug regimen already. And these patients get treatment, transplant, and then maintenance. And they just reported this induction period of time. And in general, small numbers of patients, they all completed induction. What was the response? Everyone responded. Now, 3 or 4 drug regimen, 95% of patients respond. So 100%, not that much difference. But 100% of them were MRD negative, meaning their bone marrow was cleared of any number of myeloma cells that you could detect. Now, we know they're still there, but as far as detecting it, we couldn't detect it. 20% of patients had fever and low blood pressure, or fever and hypoxia, or needed extra oxygen. And they call that cytokine release syndrome. It's an inflammatory occurrence that happens within the first week of getting a bispecific antibody. And about half of the patients had seriously low numbers of white cells, and that corresponded to about 40 to 50% of patients having serious infections, often needing to be hospitalized for that infection. So not without some risks. Okay, my advice for you. If your doctor does not do myeloma full-time, you are doing it yourself. It's a DIY project for you. So you have to be your own advocate, because in the waiting room, you are the only myeloma patient there. Everywhere else is breast, lung, colon, prostate cancer. That's everyone that you see. So you must track your own data. Now, our favorite patients are engineers and accountants because they love numbers. And they just naturally put everything on Excel and draw a graph. And part of HealthTree's foundation, their software, is to track your own labs because it's actually challenging to track your labs. You know, when you get your infusion, they always give you a paper. Here's your CBC. Who cares what my CBC is? Why are you handing it to me? Hand me my myeloma labs. That's what I want you to follow. So if you don't have a myeloma doc, somebody who's doing it full-time on your team, you must be the master of your own data. This applies even if you have a myeloma doctor you see once a year, twice a year. You still must follow your own data on Excel or Google Sheets or whatever. Make friends with acyclovir and valacyclovir. These are wonderful friends for the vast majority of myeloma patients. They stay with you, they'll be with you late at night, and they will always do their job, which is keeping you free of shingles for the rest of your life. And I want to be free of shingles the rest of my life, and I want all my patients to as well. If you are on Revlimid, Pomalyst, or anything like that, thalidomide or iberdomide, mezigdomide, but most of you, it's Revlimid and Pomalyst that's FDA approved. You must remember these drugs increase your risk for clots in your veins, which is DVTs in your legs, pulmonary emboli in your lungs, or strokes and heart attacks. So there's a threefold increased risk of these events of clots in your veins and twofold increased risk for strokes and heart attacks. You must think about this when you're taking these drugs. Now, that doesn't mean you think about it every day. You just need to say, hey, do I need to be on some aspirin, some Eliquis? Are my platelets too low for this type of shenanigans? Like, what's going on? So just be sure you're thinking about it along the way. This is not something where you want one of these clots slowing you down and interfering with your survival. Lastly, eating organic, taking supplements, trying to boost your immunity is not possible except for inbred mice in research laboratories over at Winchip. So if you are an inbred mouse, we can boost your immunity. But for none of you here can we really do that in any meaningful way with food, supplements, or diet. So don't try to avoid Fritos. I pick on Fritos for no good reason. I love them to death. And try to have a diverse diet, lots of colors in your plate. All right, that's all I have for you. Thank you very much for your time.